This is a case-based discussion following one case from my clinic, and I'll say that to start out by saying that essential thrombocythemia for years has always been kind of always the bridesmaid, never the bride of MPNs, and it's actually a really exciting time for ET because this field is about to be kind of blown up completely with new therapeutics, new ways about thinking of the diseases, and more powerful tools, which I'll highlight here that might actually really make this disease much more meaningfully treated and addressed. So, in terms of the case that I have, is a 64-year-old man. He actually is a former UN worker here in the United States, in New York City, and he developed a portal vein thrombosis. When he came into the emergency room with abdominal pain and swelling, he had labs done there, which interesting in someone who has a liver issue. Usually you see thrombocytopenia, but here there's thrombocytosis noted to 635 with a normal white blood cell count and some anemia of 10.6. The initial hematology team inpatient was rightfully in anyone with a new acute portal vein thrombosis that doesn't have cirrhosis. Checked a JAK2 mutation, which was positive with a variant allele frequency of 14%. And diagnostically, a bone marrow biopsy was performed, which was consistent with essential thrombocythemia by risk classification. He's deemed to be R IPSET thrombosis high risk. So, how do you manage a patient with essential thrombocythemia? So, here I'm highlighting the NCCN guidelines that show that if you have someone who is very low risk, which is JAK2 wild type, no thrombosis history, age less than 60, you really are just talking about managing cardiovascular risks. And you can consider aspirin for patients who have vasomotor or microvascular symptoms. But in very low risk patients, the use of aspirin is not even well described. So many of these patients can just be monitored. And low risk patients, who are those who are younger without a thrombosis but JAK2 mutated, or older patients without a JAK2 mutation and no prior thrombosis, this is really where you're talking about starting aspirin therapy on them, low dose aspirin, 81 milligrams per day. There is data I will note about doing twice a day aspirin or 3 times a day aspirin, which some patients I will encourage more for symptomatic relief. But usually 81 milligrams a day can get you through. Now, what we're really going to talk about is high risk ET, which is anyone who's had a blood clot before or those older JAK2 mutated patients. And in addition to aspirin and managing cardiovascular risk, cytoreductive therapy is really recommended. And as of the present NCCN guidelines, the choices are for clinical trial or hydroxyurea, with other recommended for select cases, including pegylated interferon or anagrelide. So, where does this really come from? Well, I will note that unlike actually PV, hydroxyurea has data to suggest that it really does prevent the development of thrombosis. This is a older study of about 110 patients randomized to either control or hydroxyurea. You can see those who had hydroxyurea significantly drop their count, while those who were treated with control had sustained elevations. And those randomized to hydroxyurea had a significant reduction or a significant improvement in their thrombosis free survival compared to those with control. I'll also note here as a side that the platelet goal that was used here was 600,000. So many times we always try to normalize the platelet count less than 400,000. But this is the only trial to really demonstrate a benefit for cytoreductive therapy in ET. Use a higher goal, which is often something I will apply as well in these high risk patients. But if you look at should you cytoreduce every patient, should you give cytoreductive therapy for every patient with essential thrombocythemia? I think the answer to that is no. This is a trial of intermediate risk patients, which were kind of arbitrarily defined as those who were 40 to 59 with no prior thrombosis, and they were randomized to either aspirin plus hydroxyurea or aspirin alone. And as you can see here, similarly, there was a significant reduction in the platelet count of those patients treated with hydroxyurea. But in contrast to the high risk situation, there was no difference in event free survival, which was really thrombosis or bleeding or death. So, in intermediate risk patients or low risk, I think the use of hydroxyurea falls back more on the development of symptoms or the use of cytoreductive therapy about symptoms and about how we can address the patient's very high platelet count in the setting of things like acquired von Willebrand syndrome. but it shouldn't be given carte blanche to any lower risk patients. Now, how about other types of cytoreductive therapy? So, first, I'll talk about pegylated interferon, and this has been compared in two different trials, which was combined with populations that included polycythemia vera or prefibrotic myelofibrosis or myelofibrosis, and the first is the MPNRC 112 trial, which randomized patients with that included 81 ET patients to either hydroxyurea or pegylated interferon, and the second is the Dahlia trial, which randomized a large group of NPM patients to either hydroxyurea or pegylated interferon. So what I'll highlight here is that this complete hematologic response, getting normalization of the platelet count, getting normalization of the hematocrit and white blood cell count, was basically equivalent between these two different groups. And in the MPNRC trial, that again, there's no really difference between the groups between those who were treated with hydroxyurea and peg interferon and discontinuation rates due to adverse events. Although there was more discontinuation due to adverse events in the interferon group in the Dahlia trial. But again, as Gabby had mentioned earlier, that interferon-based therapy did lead to a higher reduction in the JAK2 V617F allele burden in both of these trials as compared to hydroxyurea with interferon, suggesting too that this might have more of kind of a disease modification aspect to it. So in terms of this patient, he was actually started on hydroxyurea 500 milligrams daily, had normalization of his platelet count, had some mucositis, which was tolerable, but then 2 years in developed a medial leg ulcer, which is an indication you must stop hydroxyurea. So then he's asking what's the next steps for treatment of his essential thrombocythemia. So again, we have some data for interferons, but the newer one is the logical question is, given all of the success for Ropeg interferon and polycythemia vera, can Ropeg interferon be used in essential thrombocythemia? And the answer to that question was really asked by the Surpass ET trial, which was recently presented and published in last year's ASCO, and then and now recently published. And this is a randomized phase 3 multi-center active controlled open label study. It took patients who had hydroxy or essential thrombocythemia that was resistant or intolerant to hydroxyurea and interferon naive, and randomized them 1-to-1 to either Ropeg interferon or to anegrolide, which is a phosphodiesterase inhibitor that's a very commonly used second line agent. And I will highlight here that, and Rami mentioned this before in our discussion, that unlike in polycythemia vera, they used what we call a rapid accelerated titration, which was during the first dose was 250 milligrams or micrograms, and then 350 micrograms, and then just straight to full dose 500 micrograms during this time period. The primary analysis was done at months 9 and 12, and this really looked at the modified ELM response criteria. And this was 174 patients across 59 sites, largely in Asia, with some representation in the United States and Canada. So here's the primary endpoint. So the primary endpoint was this modified ELN response criteria, which was a greater than 10% 10-point decrease in MPN SAF TSS for at least 12 weeks, normalization of the peripheral counts for at least 12 weeks, in absence of any thrombosis or disease progression. And this occurred in 42.9% of the Ropeg interferon groups versus only 6% in the anegrolide group. So significantly higher response rates with Ropeg interferon as compared to anegrolide. How about the individual response modified ELM parameters? And here you can see suggesting benefit across these different parameters when you look at Ropeg interferon versus anegrolide. Higher absence of hemorrhagic or thrombotic events, symptom responses, improvement or non-progression of spleen size, peripheral blood count response, white blood cell count response, and even platelet count response. So across these different outcome measures, Ropeg interferon seem to have a benefit. But again, the similar story to what we were talking about with polycythemia vera is that a real benefit of this drug is the ability to reduce the allele burden. And if you look at these waterfall plots here, you can see all of the patients in the trial, and the ones who really got reduction in the variant allele frequency of JAK2 were almost all orange, representing the Ropeg interferon patients, very rarely in the anegrolide groups. In contrast, those patients who had an increase in the JAK2 allele burden were really almost entirely those who were treated with inegrelide. And a similar story is in the calreticulin, although much less common than JAK2. You can see reductions in the calreticulin mutational burden in many patients treated with ropeig interferon and not as much as with inegrelide. So this really supports its potential approval for the use in essential thrombocythemia, and something that we look forward to having in our toolkit. Now, what about newer drugs? One is LSD1 inhibition, which is a drug called bomedemstat, and this really works by getting by preventing megakaryocytes from maturing, and in that process, it reduces the amount of platelets made, but it also reduces the amount of inflammatory cytokines produced by those mutated megakaryocytes, and reduction in the mutant cell burden in mouse models of MPNs. In treatment with bomedemstat in these mouse models showed decreased platelet counts, splenomegaly, inflammatory cytokines, mutant cell burden, and increased overall survival. And here you can see that bomedemstat in this phase 2 trial, which was just recently published, really significantly reduced the platelet count. And this drug has to be titrated to keep in a tight range, but the majority of patients had a really good control of their platelet count. But very importantly, these patients who had high white blood cell count to begin with, they also had improvement in normalization of the white blood cell count over time. So this is a drug that is in further phase 3 development right now and may enter the treatment armamentarium in the future. But probably the most exciting development in the world of essential thrombocythemia is that with targeting mutant calreticulin. So calreticulin is present in about 25% of ET patients. And because it is localized to the cell membrane, from where it is in the endoplasmic reticulum through the Golgi apparatus up to there, it really serves as this neoantigen, which can then be targeted with things like a mutant calreticulin blocking antibody. So this drug is in development, which is called Inca 033989. And I'm just going to show this one slide on this because the data is still developing and being presented at upcoming congresses, where you can see with platelet counts, even at these lower doses, you see almost immediate normalization of the platelet counts coming down very quickly on the drug, too. And at the higher doses, this is even more dramatic, where you see really very quick reduction in the platelet counts, and it stays in this normal zone. I'll also note that even at the higher doses, it doesn't seem to cause thrombocytopenia, and that it really controls the platelet counts in a good range. And because of that, many of the patients who are already on cytoreductive therapy, like hydroxyurea or negrelide, most of those were able to come off of their cytoreductive therapies and just continue on 989. In addition, there's data that it really targets the mutant megakaryocytes in the bone marrow and can reduce the calreticulin variant allele frequency. So this is really to just give you a taste of what's on the horizon. This is still very much earlier in clinical development, but it's something that I think is really promising, that could likely really expand the treatment armamentarium in patients with essential thrombocythemia.